Hi guys, welcome to my channel. Today we will discuss the last and final part of the general toxicology chapter. In the last two classes, in the first one we have discussed what is the definition and classification of poisons, how they act, and what are the different factors that modify the action of poisons over human body. On the next class, we have discussed how poisoning can generally be diagnosed in a living subject and in a cadaver. And today we will discuss how poisoning cases can be managed or should be managed in a living subject. So let's assume a case when a person who is unconscious has brought to the general emergency where you are on duty doctor, and now it's your job to diagnose and treat the person. Now how to diagnose, I have discussed in the last class that on the basis of the history and sign and symptoms you have to pinpoint at least not the specific poison but at least which class of poison is most likely the culprit. Once you have done this, your first and foremost job is to treat the person and make him stable. But once that person is stable, as poisoning is an unnatural mode of death, so there's a possibility that the person can die. So if it happens, so you have to prepare for yourself legally. So you have some legal bindings to the state also to provide them with the necessary evidence. So first we'll discuss what is the doctor's responsibility, the legal responsibilities while treating a suspected case of poisoning. Then we'll discuss how that treatment or management should be done. So the first duty of a doctor in case of a suspected poisoning. Treats a patient who is suspected of poisoning, the first and foremost duty is to save the life of the patient and stabilize him. Once that is done, once the patient is stable, then you should remember about what legally you should be doing. Legally, first you must be noting a detailed history of that. Once the patient is stable, now you have time. Initially, you have just taken the prominent parts of the history, that what are the comorbidities he is suffering from and what are the drugs or chemicals which are available in his vicinity and whether anyone has seen him consuming anything. But other than that, once the patient is stable, you should tell a detailed history. Then you have to collect the different samples. What are the samples? You need to collect the blood, urine, vomiters, if there's any, and also the gastric lavage return. Gastric lavage return means a stomach wash is done, and after the stomach wash, the returning fluid is to be preserved, and police will collect it and forward it to the state forensic lab or national forensic lab for detection of the poison. Any suspected food, vial or containers also should be preserved. The patient must be admitted, not to be discharged for observation, and you should discuss the case with a senior practitioner. So if you are a private practitioner and you are convinced that the patient has visited you after consuming something, you are duty bound according to the Criminal Procedure Code of 39 to inform the police. If he is confirmed that the patient is suffering from a suicidal accidental poisoning, however, that is suicidal consumption, it is advisable to inform the police. But if the patient categorically requests you not to inform the police, then the private practitioner can choose not to inform the police, but you must state a written consent from the patient that it is his or her that she will in her own his or her handwriting will write that the consumption of the poison was suicidal or accidental in nature. He or she is taking the full responsibility and he or she does not wish to inform the police. You must state that in writing. That's for the public practitioner, for a private practitioner. For a government medical officer, doesn't matter which is the manner of consumption, suicidal, accidental, homicidal, in any case of poisoning, the police must be informed. If the patient becomes serious and dying, then dying declaration should be noted. If the patient dies, death certificate should not be issued and the body will be sent for the autopsy. And after autopsy, the autopsy surgeon will preserve the necessary samples. The sample preserver, how the sample should be preserved, we have discussed. And the samples will be sent to the CFSL, and until and unless the report from CFSL comes back, you should not comment anything regarding the nature of the poison to the patient party. Okay, so these are the legal responsibilities. Now, as I said, first the patient has to be stabilized. Now, treatment should be done. Of a suspected case of poisoning consists of 5 stages. First is the initial resuscitation. Resuscitation means stabilizing the patient. The patient has to be stabilized. For this, the algorithm, the protocol followed is formed under the general trauma care management. The standard protocol is the basic life support or BLS or its advanced version. First one is it is divided in 5 sub-steps: A, B, C, D, E. A for airway, B for breathing, C for circulation, D for diagnosis, and E for evaluation. So after the resuscitation is done and the patient is stable, then comes removal of the unabsorbed poison from the body. All of the poison is not absorbed, some are not yet absorbed, so that part needs to be removed. So that is called removal of unabsorbed poison, is also known as decontamination. This is also known as decontamination. The next one is the neutralization of the effects of poison. The poison will have some effect. It will elevate the blood pressure or depress it. It will cause arrhythmia or convulsion, whatever. So those effects needs to be neutralized by specific drugs or by giving specific antidote. Elimination of the poison reabsorbed. That means elimination must be increased, and then symptomatic treatment if there's any. We will learn the initial resuscitation. So CAB must be maintained. CA circulation, airway, and breathing. So circulation. For the circulation, chest compression is done to get the heart pumping at a regular interval. Then airway must be positioned and secured. This to the head tilt. Head is tilted backwards. Chin lift. Chin is lifted, and if there and mouth and the head should be turned sidewise so that any collection in the mouth is drained. In case of a poisoning, you should turn the patient to one side and remove any collection or mucus from the mouth. However, for any injury or head injury cases, you must not remove the head because you can further aggravate the neck injury. In poisoning, there's no such case, so head can be moved and so that the suction can be done. So after head tilt and chin lift, for regularization of the breathing, you can try mouth to mouth breathing or artificial breathing by ambu bag. From the next step, removal of the unabsorbed poison or decontamination. So if the poison is applied locally, as here something has fallen on the eye, so normal saline is poured on the eye to wash it away. On the skin should be washed thoroughly with water. Do not apply any alkaline solution in case of acid burn, because the acid and alkali reaction, it's kind of an exothermic reaction. So the liberated heat will further aggravate the injury. In case of an acid burn on the skin, it should be washed with plain water. Plain water is sufficient. And for any pesticide or agricultural poison injury, you must remove all the clothing and the patient's entire body surface area should be cleansed well with water, if necessary then with soap, because all agricultural poison pesticides, they can be absorbed through intact skin. So any remnant part which is on the skin must be removed, unless if you don't do that, then that agricultural poison will be absorbed to the skin. So after washing and change of the clothing, for an injected poison, it is a common practice to apply a tourniquet. So but this should not be done, because this tourniquet will hamper the blood circulation and eventually it can lead to gangrene. So that will further aggravate the injury. So in case of a snake bite event, tourniquet application is not always advised by an untrained person. By a trained person, tourniquet can be done, but it should be loosened once in a while, every half an hour, so that somewhat circulation is maintained to keep the limb healthy. That is the unabsorbed poison from the skin. The poison which is ingested, but some part of the poison is still remaining from the stomach. So some method should be there to remove that unabsorbed poison from inside the stomach. There are three methods: gastric lavage or the stomach wash, induction of vomiting or emesis, and catharsis or purging is induction of a diarrhea. So it will be either vomiting, or it will be expelled through mouth, or catharsis, it will be expelled with stool. So first we'll read about gastric lavage. Gastric lavage is the most widely applied technique for removing stomach wash, so that unabsorbed poison from the stomach can be removed. Ideally, it should be done within 2 to 5 hours of consumption of the poison, because the standard gastric emptying time is 4 to 6 hours. So after 6 hours, it doesn't have much value, except in few scenarios which I mentioned in my earlier class, that some poisons which undergo enterohepatic circulation, that is through liver, it is again secreted within stomach. So those poisons can be removed by stomach wash even after 6 hours. For example, opium. Opium, even if injected, as it undergoes enterohepatic circulation from liver, it is again comes into stomach. So in that case also, stomach should be washed. Or some poison like salicylates, which are sticky and they form a clump and they remain in stomach for a longer time. For these, stomach wash can be given after 6 hours. But other than this, in no case, stomach wash doesn't have much value if given after 6 hours. However, off the record, practically in any poisoning patient in India, whenever it comes, our one stomach wash, at least one round of stomach wash or gastric lavage is done to reassure the patient party that we have tried stomach wash to save the patient. Contraindications of gastric lavages. There are two groups of contraindication: absolute contraindication and corrosive poisoning. Because in corrosive poisoning, the stomach wall is very friable and weak. So while giving stomach wash, if you insert the gastric lavage tube, the tube can puncture stomach wash. I'm sorry, the tube can puncture the stomach wall. So with corrosive poisoning, gastric lavage is absolutely contraindicated. Any type of volatile poisons like kerosene, it is absolutely contraindicated. The patient is in coma, airway is unprotected. So gastric lavage is absolutely contraindicated because it can lead to aspiration pneumonia. What are the relative contraindications? Relative contraindications means gastric lavage can be given but with some relaxation. According to some book, volatile substances falls under relative contraindications, but I would say they should be under the absolute contraindication, because anything that can cause aspiration pneumonia is an absolute contraindication. Poisoning by strychnine, it's a relative contraindication, because here convulsion can be precipitated. deep unconscious patient or in advanced pregnancy, gastric lavage is avoided. Now, how it is driven? It is driven by tube. Tubes are usually the classical gastric lavage tube, E.D.T.A or boas, or a rice tube or an infant feeding tube like this, or by a lavature. First, you have to put the patient on a bed, have an intravenous access so that saline can be given. Place a cardiac monitor if the patient is an elderly or in history of cardiac disease. Restrain the patient if the patient is not cooperative. Then you need to measure the length. What is the length measured? The length is from the upper central incisor to the one side of tragus of the ear, then from the tragus up to the xiphisternum. This total length is the appropriate length of the rice tube that should be inserted, so that one end goes beyond the cardiac end of stomach and reaches the lumen. After measuring it, you should grease it well with gelatin jelly, and then it is passed gently through mouth to avoid damage to the posterior pharynx. There should be an mouth block or oral block so that the patient does not bite on the tube. Then a 50 ml syringe is inserted to the external end, and through the empty syringe air is pressed inside by pushing the plunger. The diaphragm of the stomach is pressed on the epigastrium, and once the air enters stomach, one sound is heard to the stethoscope. That sound confirmed that the other end of the stomach, the other end of the gastric lavage tube or Ryle's tube is inside stomach. Then remove the gastric content by suction, by pulling back the plunger. This must be preserved for the toxicological analysis. Small boys, then repeatedly normal saline or any other water should be pushed, and it is then the water is pushed, then it is sucked, pushed and then sucked. Such a way stomach is washed. Perform this step. The patient should be in the left lateral position. Why? To avoid aspiration. Then when the return in fluid is absolutely clear, then you should stop this procedure. After that, at the end of it, after that, in the last, a slurry of activated charcoal. We will discuss what is activated charcoal. A slurry of activated charcoal through the gastric tube, it is pushed. Okay, so that is how the gastric lavage is done. What are the solutions used? Saline or plain water. The fast lavage return should always be preserved. Potassium permanganate, a dilute solution for oxidizable poisons like alkaloids, salicylates. Calcium gluconate for oxalate poisoning, as it will form calcium oxalate. Sodium thiosulfate for cyanide poisoning, as it will form sodium thiocyanate, which is non-toxic. Desferrioxamine is a chelating agent for iron poisoning. It can be driven through gastric lavage. Activated charcoal can be driven by gastric lavage tube, as it is a slurry and it is very bad test. It cannot be ingested by the patient, so it is better be passed through the rice tube or gastric lavage tube. In the next phase of decontamination, process of decontamination is catharsis or purging. Catharsis is the helpful to it is used to remove the unabsorbed material from the GI tract. However, it is contraindicated in corrosive poisoning, existing electrolyte imbalance, and in paralytic alias. However, all the cathartic solutions that are either in the, especially the ionic ones, they are sodium based or magnesium based. So any type of existing electrolyte imbalance, this particularly this ionic variety must be avoided. Ionic type are usually sodium based or magnesium based. The side effects are electrolyte imbalance. If you have the sodium based solution, that can lead to hypernatremia. If you use the magnesium based solution, it can lead to hypermagnesemia. The other variety are the saccharides. Saccharides may so the sorbitol is the most widely used. Sorbitol is the catheter of choice in case of adults, but not in children. In children, it must be avoided because it can lead to fluid retention and electrolyte imbalance. More violent from a pretarsis is the whole bowel irritation. In the whole bowel irritation, it's a bowel is induction of violent diarrhea. It involves the installation of a large volume of a solution into the stomach by a nasogastric tube over a period of 2 to 6 hours, producing voluminous diarrhea. Most commonly used compound is the polyethylene glycol. It is colloquially termed as PEDLEC. It is given continuously till the rectal effluent is clear. What are the indications? Indications are ingestion of a large volume of a toxic drug. When the large volume is ingested and all cannot be removed by stomach was, and the duration is more than 3 to 4 hours, so the chances that part of it is in the small intestine, then you go for a whole bowel irritation. Overdose is a sustained release preparation. Sustained release preparation means some part is in the stomach, some in the duodenum, some is absorbed. So to remove the unabsorbed part, whole bowel irritation is the way. Ingestion of the substances which are not absorbed by activated charcoal, like heavy metals. Heavy metals, they are not absorbed by activated charcoal. So for them, either do a gastric lavage. If the patient comes late, then do whole bowel irritation. Okay. Ingestion of a foreign bodies for as miniature GITS batteries like the button batteries, or protein filled packets in body pattern syndrome. Body patterns are in the persons which are used that drug mule to smuggle drug from one country to another. What they do, they put cocaine or heroin inside balloons or condoms, and those balloons, they are ingested. So these balloon filled with drugs, they are inside the stomach. Some go into the duodenum. So if they're intervened by the patient, intervened by the customs, and they are brought to hospital to remove those bags filled with drug, whole body irritation is done. Ingestion of a slowly dissolving substance like iron tablet, pain chips, etc. Bezos are inedible substances like hairball or something which is ingested by a mentally ill person. To remove that, whole body irritation is the way. Because you cannot remove hairball by inducing vomiting. Next is the neutralization of the effects of poison by antidote. Any substance which counteracts or neutralizes the effects of poison. It will counteract the effect. That means the further effect will not be produced, and it will neutralize the effect. That means whatever effect is already produced, it will have the reverse effect. So what are the different types of antidote? The three types. First one is the mechanical antidote. Mechanical antidotes are they neutralize the effect of the poison by the mechanical action, like activated charcoal. Activated charcoal, they absorb the poison over their surface due to their physical property. Demulcent drink. Demulcent are they are the colloidal substances which are driven like milk or egg yolk, which are driven primarily in the corrosive and irritant poisoning to protect the stomach mucosa from further damage. So these are the mechanical antidote. Then comes chemical antidote. They neutralize the effect of the poison by chemically reacting with the poison and forming a harmless compound like gelatin agent. Chelating agent, they will bind with the heavy metal to form a non-toxic chelate compound. Copper sulfate is itself a poison, but it can be used as an antidote in phosphorus poisoning because copper sulfate reacts with phosphorus based compound to form cupric phosphide Cu3P2, which is a non-toxic substance. So it's an example of chemical antidote. Physiological antidotes are which act on the body and produce action which is exactly opposite to the action of the poison, like atropine and physostigmine. Atropine is anticholinergic. It will block the acetylcholine receptor. Physostigmine, what it does, it inhibits the acetylcholine esterase enzyme. So more acetylcholine is there to bind with the receptors. So they have opposite actions. So this is an example of physiological antidote. So in atropine poisoning or anticholinergic poisons, physostigmine is an antidote. How they act, what are the different mechanisms? Number one, inert complex formation, like the chelating agent. As I said, chelating agent with heavy metal, Prussian blue for thallium, antibody fragment for digoxin, dicobalt E.D.T.A for cyanide. They form the inert complex. Accelerated detoxification, that means they enhance the hepatic detoxification of the poison, like thiosulfate. They can directly react with them, like thiosulfate. It reacts with cyanide to form thiocyanate. Acetylcysteine, in it is an antidote for the hepatotoxic poisons like paracetamol. Acetylcysteine acts as a glutathione substitute and it binds with paracetamol, detoxifies them. So any paracetamol overdose, acetylcysteine can be used as an antidote. Reduce toxic conversion. So methanol poisoning, methanol is found as an impurity in the tranquilitors. So in a tranquilitor poisoning, the offending toxic chemical is the methanol, but methanol itself is not poisonous. Methanol is acted upon by the enzyme alcohol dehydrogenase to form formaldehyde. This formaldehyde is actually producing the toxic symptoms. So the antidote is ethanol. You drink ethanol. So ethanol is also acted upon by the alcohol dehydrogenase enzyme. So ethanol will compete with methanol for alcohol dehydrogenase enzyme. So formaldehyde will not be produced. So that toxic conversion is reduced. Receptor site competition, like naloxone. Naloxone is an opioid antagonist. So for any type of opioid poisoning, naloxone is used as an antidote. Receptor site blotted. Atropine, it blots the effect of anticholinesterase agent for its organophosphate at the muscarinic receptor site. So organophosphate, they inhibit the anticholinesterase enzyme. So acetylcholine is available in much larger quantity to bind with the muscarinic receptors. Atropine blocks those muscarinic receptors. Toxic effect bypass. Use of 100% oxygen in cyanide poisoning. Cyanide inhibits the electron transport chain. So use of 100% oxygen will help to bypass the toxic effect. Now, what does activated charcoal does? Activated charcoal has documented efficacy as the sole decontamination measure. So the recent studies, the recent papers, they all have questions about the efficacy of gastric lavage or catharsis or purging, MACs, because they are, first of all, they are barbaric procedures. They put the patient to much discomfort, plus they have many contraindications and they can lead to many disastrous side effects also, which can endanger the patient lives further. But activated charcoal is the sole decontamination measure which have documented efficacy without much side effect. These are fine black or odorless, tasteless powder that dissolved in water to form a slurry, which can be consumed or orally, but it's not a very pleasurable experience. So it can be driven by gastric lavage tube. It has a large surface area, so it facilitates absorption of the poison. Not, please, this is not a spelling mistake. This is not absorption. This is adsorption. Adsorption means the poison goes inside in the surface cracks of the particles. So this is adsorption. How these are produced? Carbon from the coconut shell, bone, wood, etc. It is subjected to a destructive distillation. Then the carbon monoxide, carbon dioxide or steam, it is passed through under the high pressure. Purification is done. After that, activated charcoal is produced. So this is an activated charcoal particles. These are macropores, these are micropores, these are mesopores. So macropores are big orifices, micropores are small orifices, mesopores are in between. So in these pores or cracks, in the macropores the large particles enter, in the micropores and mesopores small particles enter. This is how an activated charcoal acts. In the stomach, the activated charcoal will disseminate in the entire stomach. Surface area is more, so up to 60% of the toxic substance is documented to be absorbed by the activated charcoal. It is useful in antidepressants, atropine, barbiturates, benzodiazepine, chloroquines, NSAIDs, opioids, phenothiazines, and strychnine. They should be given within first 2 hours of ingestion, as after that stomach would have, after that either most of the poison is absorbed into the circulation or they have entered duodenum. Disadvantage: unpleasant taste. It can induce vomiting or constipation, diarrhea. It can lead to intestinal obstruction if multiple doses are used. And if the patient ingests it and it is unpleasurable experience, sometimes it coughs, and during coughing some part can enter the bronchus due to aspiration. So these are the disadvantages. Contraindications are mostly the absent bowel movement cases in the paradialysis or any type of small bowel obstruction. They should not be given as they are likely to aggravate the situation. Prostate injection, in case of caustic soda or caustic potash, they are not very much effective in any corrosive poisoning per se. They are not very effective. In case of corrosive poisoning, the only decontamination measure effective is Demulcent. You cannot give gastric lavage. Activated charcoal are not much effective, so Demulcents are the only way to go. Injection of petroleum distillates like the kerosene or any volatile. So this is all you should know about activated charcoal. What are the chelating agents? Are polycyclic compounds which form an addition compound or an adder with the heavy metals. So they form a metal chelator complex which is non-toxic, so which is then easily excreted through kidney. So how the heavy metals act? Actually, heavy metals, they have a huge affinity for the sulfhydryl groups. Okay, so this is aspirin and heavy metal. This is an enzyme which has a sulfhydryl group. So now aspirin will bind with the sulfhydryl group of the enzyme to form a heavy metal enzyme complex. Now this enzyme is rendered ineffective. Now what the chelating agent will do? Chelating agent will bind with the heavy metal or arsenic so that it doesn't have access to the sulfhydryl group of the enzyme. So further chelation, if so further binding of the heavy metal is not possible. Different heavy chelating agents used. First one is the British anti-lewusite or B.A.L. pronounce it as B.A.L or British anti-leucide. Don't use the acronym as a word. Or dimercaprol. It is used an antidote in the heavy metals like copper, mercury, arsenic, lead, gold, thallium, antimony, etc. It is contraindicated in severe liver and kidney damage, cadmium poisoning, and G6PD deficiency. And one more important thing you must remember, that it's an oil-based formulation. So it's an oily substance, so it can only be driven by a deep intramuscular route. Another chelating agent is DMSA or dimercapto succinic acid or succinate. This is used in lead, arsenic, copper, antimony, etc. And they can be given where B.A.L is contraindicated, like liver kidney damage, cadmium deficiency, cadmium poisoning, etc. One more is the ethylene diamine tetracid acid or E.D.T.A. It is one of the most commonly used chelating agents. Its aqueous solution so can be given through IV. It is used in lead, copper, iron, manganese, cadmium poisoning. It forms a readily soluble inert complex which is later excreted through urine. Side effects are mainly fever, headache, nausea, vomiting, vertigo, etc. And it is contraindicated in renal insufficiency or renal damage patients. In case of severe lead poisoning, E.D.T.A is given only after administration of British anti-leucide, because British anti-leucide is an oil-based formulation, so it is lipophilic. It will cross the blood-brain barrier, but E.D.T.A being aqueous solution cannot cross blood-brain barrier. DMPS, it is used in arsenic, lead, mercury poisoning. It can be given orally. D-PENICILLAMINE, it's a penicillin derivative. So in case of penicillin, patients who are allergic to penicillin, it should be avoided. It is also can be given orally. It is given in copper, lead, mercury, zinc poisoning. Different chelating agent. Now the last is the elimination of poison already absorbed in the body. That means they are already in the blood. First one is the enhanced renal excretion. Orally you give plenty of water, tea, lemonade, etc. Intravenous you give normal saline infusion to increase the renal excretion. Alkaline diuresis, here the urine should be made alkaline, that is urinary pH above 7.4, 7.5 to 9. It promotes excretion of the weakly acidic drugs like salicylate, barbital, etc. Again, so the reverse acidic diuresis should be given for weakly alkaline drugs like amphetamine, strychnine, quinine, etc. The only drawback is there's a chance of inducing overhydration, so that can lead to pulmonary and cerebral edema. The diaphoretic substances which increase the excretion of poison by sweating, these are not very much used. Efficacy is very much doubtful. One is hemodialysis. Hemodialysis is a method where the blood is passed through a dialysate mixture to remove the toxic substances. It is indicated it is a must in the following situation. After heavy metal chelation in patients. So the chelation is done. Now we have a chelate and heavy metal ion complex. Now if all of them are not removed by the kidney, some of them are circulating in the blood, so they should be removed by hemodialysis. After renal failure, in any patient, dialysis should be done. Any nephrotoxic patients, ethylene glycol or methanol injection, this is a must because these are nephrotoxic. Dialysis is usually effective in lithium, phenobarbital, salicylic, theophylline, etc. And hemodialysis can be given if the antidote is not effective, or the patient comes late, or the patient is very much serious in alcohol, amphetamine, short-acting barbiturates, and chloral hydrate poisoning. So these are the indications of using hemodialysis as a treatment measure in poisoning. So this group is where hemodialysis is a indication, doesn't matter which is the condition of the patient. This group, hemodialysis is indicated if the treatment modality is not working, and this in this group dialysis is indicated as a last resort if the patient is not responding to the treatment. Okay. In hemodialysis we have hemoperfusion. So in hemodialysis there is a dialyzer mixture through which the blood is passed. Hemoperfusion, here the blood is passed through a perfusion column. However, in hemoperfusion, the optimum or prior heparinization of the venous lines is a mandatory. So here there's a risk of over heparinization and extra bleeding. The drugs for which hemoperfusion is indicated, and these are the drugs where hemoperfusion is better, acts better than the hemodialysis. In barbiturate poisoning, organophosphates, paraquat, paracetamol, benzodiazepine, phenol, salicylate, etc. So nowadays, for a treatment of poisoning, hemoperfusion is much more preferred than hemodialysis, because hemodialysis should be preserved for patients which have renal insufficiency, end stage of renal failure, viper snake bite, for those patients. And for other poisoning patient, hemoperfusion is an better method as it is less complicated but better efficacy. Peritoneal dialysis, hemofiltration, these are other methods. Plasmapheresis is where you take out the blood, you separate it, plasma and cells. Cells are uh, suspended in a colloid and they are reperfused, and the plasma which is taken out is replaced by transfusion of the freshly frozen plasma. So plasmapheresis can also be done in some serious condition or exchange transfusion. So these are the different methods where the blood poison which is already absorbed into the system can be removed. So it is either hemodialysis or peritoneal dialysis, or hemoperfusion, hemofiltration, plasmapheresis, exchange transfusion. These are the 6 methods which can be used. Which is to be used depends on availability of the technique and condition of the patient. So this is the outline of the management of a patient treatment in a suspected case of poisoning. The chronology must be maintained. First, you stabilize the patient, then go for decontamination. If there's any poison is on the body surface, wash it with water, change the clothing. Then go for gastric lavage where it is contraindicated. Do not give. In case of corrosive poisoning, only decontamination measure effective is the demulcents like milk or the egg white, the colloids. For all other cases other than corrosive or volatile poisoning, you should give activated charcoal after the gastric lavage, even if it is given. If then elimination, then further to remove anything left is the whole bowel irrigation if the patient comes late, or the specific indication like body packer syndrome or Bezos or a sustained release preparation, large volume of blood, etc. Then come in specific treatment by using the specific antidote. We know what are the antidotes, what are the different types of antidote, how they act. We have talked about chelating agents. Then as we take up one after another poison, we will read about specific antidote of that poison under that chapter. Then comes the removal of the poison which is already absorbed in the blood. For that, we have 6 methods: hemodialysis, peritoneal dialysis, hemoperfusion, hemofiltration, plasmapheresis, exchange transfusion. Symptomatic treatment: if the patient have any symptoms, you treat that accordingly. So thank you for listening. Thank you for your time. Go through the chapter. This is an important chapter. I have tried to make it as easy as possible. And if you have any doubt, please feel free to reach to me. Thank you very much.